Hello and welcome back to the deep dive. Today's going to be a little bit different.
A lot different, actually.
Yeah, true. If you've been with us for a while, we usually take a broad concept like, I don't know, the history of coffee or the mechanics of blockchain, and we sort of leisurely float through the details.
Right, but
Today, we are putting on the scrubs. We are stepping right into the rhesus room. We have a very specific mission for you today.
we certainly do. This isn't just a casual chat. This is a survival guide. We are simulating the mind of an emergency physician preparing for the MRCEM primary exam.
The MRCEM Primary, just saying the name induces a little tachycardia in some people.
Oh, absolutely. It's
Yeah.
a beast of an exam.
Yeah.
It is the gatekeeper.
Yeah. And the thing about this exam, the reason we're doing this deep dive is that it doesn't just want you to know anatomy, it wants you to know applied anatomy.
Exactly.
Yeah.
It is not enough to just, know where a nerve runs in a cadaver. The written paper format explicitly tests your ability to apply it.
Mm-hmm.
You need to know what happens when a drunk patient falls off a bar stool, hits their head, and suddenly can't look down.
Right.
The exam is testing your ability to work backwards, to see the clinical deficit in front of you and visualize the anatomy that has failed underneath the skin.
So, here's the plan. We have compiled a massive stack of research, past papers, anatomy textbooks, clinical guidelines, and we have distilled it all down into 100 high-yield clinical scenarios.
100.
100. These are the points that come up again and again and again.
And we aren't just going to list them. That would be incredibly boring, and frankly, you wouldn't remember them for the paper. We're going to treat this exactly like a shift in the emergency department.
I love that approach.
We'll present the patient, identify the pathology, and then, and this is the absolute key for the exam, we will extract the single high-yield anatomical structure that the board wants you to mark.
Perfect. We've got a ton of ground to cover, so we've structured this chronologically through 5 key anatomical sections to keep it, organized in your brain.
Keeps the mental filing cabinet tidy.
Exactly. We're starting with cranial nerves, then moving to the eyes. Ophthalmology is huge in this exam. Then we'll tackle the central nervous system and spine, move on to the skull and foramina, which is basically the trauma section, and finally, we'll finish up in the thorax.
And just to make sure you're actually retaining this and not just nodding along while you drive or wash the dishes, we're going to pause after each major section for a rapid-fire assessment.
A little pop quiz.
Exactly. I'll throw the concept at you, and I want you to shout the answer at your dashboard before I do.
High pressure, high reward. I love it. Let's not waste a single second. Section 1, cranial nerves and reflexes. We're diving straight into the head and neck.
Let's do it.
Okay, picture this. You have a patient sitting in the chair. You're doing a routine cranial nerve exam. You get your tongue depressor out. You touch the back of their throat to test the gag reflex. And nothing. No gag. But specifically, you also notice they complain they can't taste anything on the very back of their tongue. What is the single high-yield structure here?
That is the glossopharyngeal nerve, cranial nerve 9.
Now, let's unpack this for the written paper. Why does the exam care so much about this specific nerve for the gag reflex?
Because the exam loves, and I mean loves, to separate the reflex arc into its distinct components. A reflex has an input and an output. The glossopharyngeal nerve is the afferent limb.
Meaning the input.
Right. It's the messenger that says, hey, brain, there's a stick poking the back of the throat. It supplies sensation and taste to the posterior 1/3 of the tongue. If that specific wire is cut, the signal never gets to the brain in the first place, so the gag never triggers.
Okay, so that's the input. Now let's contrast that with this scenario. You ask the patient to open wide and say, ah. You look at the uvula, and instead of staying perfectly in the middle, it deviates away from the affected side. It's pointing towards the healthy side.
That points directly to the vagus nerve, cranial nerve 10. The vagus is the efferent limb of the gag reflex. It is the motor response that actually contracts the muscles in the palate.
Why does the uvula point away, though? I always found this completely counterintuitive when I was studying.
It trips a lot of people up. Think of the uvula as the little flag on the rope in a tug-of-war.
Okay.
The soft palate muscles on the left are pulling left, and the muscles on the right are pulling right. If the left vagus nerve is paralyzed, the left muscles just go limp. They stop pulling entirely.
Ah, so the right side just takes over.
Exactly. The right side is still strong, so it pulls the uvula over to the right. The uvula deviates away from the lesion. The written paper will definitely test your understanding of that directional pull.
So for the exam, we need a solid way to lock this in. Input versus output for the gag reflex.
Simple mnemonic. 9 goes in, 10 goes out.
9 in, 10 out.
Right. Cranial nerve 9 senses it. That's the afferent end. Cranial nerve 10 acts on it. That's the efferent out.
9 ins, 10 out. I like that a lot. Let's move down the neck just a bit. You have a patient who just had thyroid surgery, maybe a thyroidectomy for cancer or Graves' disease. They come into the ED complaining of a really hoarse, husky voice.
This is a classic iatrogenic injury, meaning we, the doctors, unfortunately caused it. The high-yield structure involved here is the recurrent laryngeal nerve.
And this is a branch of the vagus, right? Why is it so vulnerable in this specific surgery?
Anatomy is destiny here, and the exam board knows it. The recurrent laryngeal nerve travels down into the chest and then loops back up.
Hence recurrent.
Exactly, hence recurrent. It loops back up to supply the vocal cords. It runs right in the tracheoesophageal groove, intimately close to the posterior aspect of the thyroid gland. When a surgeon is tying off the inferior thyroid artery, that nerve is often just millimeters away.
So if you nick it,
or even just stretch it too much, the vocal cord on that side becomes paralyzed. That's why you get the hoarseness. It's a very common exam question because it perfectly links a surgical complication to local anatomy.
is one side more at risk than the other?
Functionally in the neck, they are both at risk. But purely anatomically, the left recurrent laryngeal nerve has a much longer course because it loops all the way under the aortic arch, whereas the right just loops under the subclavian artery.
Good to know. Let's talk about shoulders and neck movement. You have a patient who literally cannot shrug their shoulders. You ask them to shrug against your hands, and they just can't do it. They also struggle to turn their head to the opposite side against resistance.
That is the spinal accessory nerve, cranial nerve 11. It's a pure motor nerve.
What exact muscles are we testing here for the paper?
It supplies the trapezius, which is your main shrug muscle, and the sternocleidomastoid, or SCM, which is what turns the head.
Speaking of the SCM, let's look at a very common fracture. Scenario number 5 involves a fracture of the clavicle, specifically the medial third. You look at the X-ray, and the proximal fracture fragment, the piece closest to the sternum, is pulled way up into the neck. Why does it do that?
It's the sternocleidomastoid muscle again. It attaches directly to that medial clavicle. When the bone breaks, the anchor's completely gone.
So it just recoils.
Basically, the resting muscle tone of the SCM pulls that free-floating bone fragment superiorly. It is a mechanical giveaway on an X-ray, and the exam absolutely expects you to know which muscle is doing the pulling.
Okay, let's move back to the face. This is often where people get a bit confused. You have a patient who has what we call kissing muscle paralysis. They can't whistle, they can't purse their lips to give a kiss.
The structure is the orbicularis oris muscle. It's the sphincter muscle of the mouth, essentially, and it is supplied by the facial nerve, cranial nerve 7.
Now, a much more serious scenario. Ludwig's angina. This is a life-threatening, terrifying infection in the ED. You have a patient with massive, woody swelling of the floor of the mouth. Their tongue is pushed up and backwards, and it is actively threatening their airway. The exam question is, where is the infection and where did it likely come from?
The infection is localized in the submandibular space, but the high-yield fact you need for the written paper is the source. It almost always originates from an infection in the second or third lower molar teeth.
Why specifically the second or third molars? Why not the incisors or the front teeth?
It is all about the depth of the roots. The roots of the second and third molars extend below the mylohyoid line of the mandible.
Okay.
Think of the mylohyoid muscle like the literal floor of the mouth. If a front tooth gets infected, the root is above that floor, so the pus just drains upwards into the mouth. It's gross, but it's not usually lethal.
But the back teeth are different.
Right. The back molars drain below that floor directly into the submandibular space deep in the neck. That's exactly why it spreads so aggressively and closes off the airway. It's a brilliant anatomical question for the examiners.
That is a crucial distinction. Okay, let's talk about nerve blocks. Emergency medicine is all about fixing things while keeping the patient comfortable. You have a nasty, deep laceration right on the midline of the forehead. Which specific nerve do you need to block to sew that up comfortably?
The supratrochlear nerve. It supplies the skin right in the absolute middle of the forehead.
And what if the cut is bigger? Say the sensation loss extends from the eyebrow all the way back to the vertex, the very top of the skull.
Then you are looking at both the supraorbital and supratrochlear nerves. They're both branches of V1, the ophthalmic division of the trigeminal nerve. They handle the sensory mapping for the entire forehead and anterior scalp.
Now, I want to spend a solid minute on this next one because it is a classic, absolute favorite exam trap. It involves referred pain. Scenario 10. A patient comes in with severe jaw pain radiating to the ear. Or maybe they complain of pain specifically when you touch the tragus of the ear. Or, and here's the absolute kicker, they have mumps and their ear is throbbing.
All right, this is the famous parotid ear connection. The high-yield nerve involved here is the auriculotemporal nerve, which is a branch of the mandibular nerve, V3.
Here is exactly where the confusion happens for candidates. The facial nerve runs right through the parotid gland. It physically splits the gland into deep and superficial lobes. So students in the exam hall always want to say the facial nerve is responsible for the parotid pain. Why is that dead wrong?
That is the classic trap. Yes, the facial nerve, cranial nerve 7, is there, but it is the motor supply to the face. It is essentially just a squatter living in the parotid gland. It runs through it, but it does not give it sensory innervation.
It's just passing through.
Exactly. The pain of mumps or any parotitis is caused by the swelling of the gland stretching its very tight fibrous capsule. That sensory signal, the actual ouch, is carried exclusively by the auriculotemporal nerve. If you tick facial nerve on that multiple choice question, you lose the mark immediately.
So to summarize, the facial nerve moves the face, but the auriculotemporal nerve feels the parotid pain. Got it. What about reflexes down in the jaw? You tap the chin with a tendon hammer and the jaw violently snaps shut. An abnormal jaw jerk reflex.
That reflex is entirely mediated by the mandibular branch of the trigeminal, V3. Both the sensory component of feeling the tap and the motor component of snapping the jaw shut are handled by V3.
And numbness of the lower lip. We see this all the time with deep chin lacerations or mandible fractures.
That is the inferior alveolar nerve, which again is a branch of V3. It runs right through the bone and the mandibular canal to supply the teeth, and then it pops out the mental foramen on the chin to become the mental nerve supplying the lower lip.
Scenario 15. This is the big one for the stroke alert in the rhesus room. You see a patient with a phalangeal palsy. Half their face is drooping, but you look closely and notice the forehead is spared. They can still raise their eyebrows perfectly on the affected side.
This is the critical, life-saving differentiation between a central stroke and a peripheral Bell's palsy. The exam will definitely ask for the anatomical explanation for this.
Let's hear it.
The upper face, specifically the forehead, receives bilateral innervation from the motor cortex, meaning both the left and right sides of the brain send wires to both sides of the forehead. So if you have a massive stroke on one side of the brain, the other side of the brain just covers for it, and the forehead continues to move normally.
Whereas in Bell's palsy,
Bell's palsy is a peripheral lesion of the facial nerve itself, usually right as it exits the skull. It cuts the main wire completely downstream of all that bilateral crosstalk, so the whole half of the face, including the forehead, is paralyzed.
So the simple rule for the exam is forehead moves equals stroke, which is central. Forehead paralyzed equals Bell's, which is peripheral.
Spot on.
Let's talk about hearing. Scenario 16. A patient has blunt trauma near the stylomastoid foramen. Maybe they took a baseball bat to the side of the head, and now they have hyperacusis. They complain that normal sounds, like a door closing or a cup dropping, sound incredibly loud and physically painful in one ear.
This is fascinating physiology. The nerve involved here is the nerve to stapedius, which is a tiny, tiny branch of the facial nerve, cranial nerve 7.
Explain the mechanism for us. Why does breaking a nerve make things louder?
The stapedius is a minuscule muscle attached to the stapes bone inside the middle ear. Its entire job is to dampen vibration. It acts like a shock absorber. When a really loud noise hits your ear, it rapidly contracts to stop the stapes from banging too violently against the oval window.
Okay, I follow.
If the facial nerve is injured high up in the canal, before this little branch comes off, you lose that protective dampening reflex. The shock absorber is completely gone. So normal, everyday sounds essentially crash uninhibited into the inner ear.
Well,
It's a brilliant clinical sign because it localizes the lesion to exactly inside the facial canal.
moving to taste. Scenario 17. Loss of taste, specifically on the anterior 2/3 of the tongue.
That is the chorda tympani. It's a special sensory branch of the facial nerve that actually hitches a ride with the lingual nerve to get to the tongue.
It's a bit of a weird nerve, isn't it? It carries taste, but it also does secretomotor stuff for the submandibular gland, right?
Correct. So a targeted lesion there gives you a very dry mouth and no taste on the front of the tongue. The examiners love it because it has dual functions.
Let's finish up this section with lymphatics. You have a patient with a firm mass on the very tip of their tongue. Where does that drain to first?
The extreme tip of the tongue drains directly to the submental lymph nodes right under the chin.
And scenario 19. Say it's an infection in the first lower molar, or a lesion on the lateral side of the tongue.
That drains further back to the submandibular lymph nodes.
Finally, just to hammer home that mumps point one more time because it is so heavily tested, scenario 20. Severe swelling of the parotid gland. Where is the pain referred?
To the ear and the temporomandibular joint, and it is carried specifically via the auriculotemporal nerve, not the facial nerve.
All right, take a breath. That was the first 20 scenarios. We have completely dissected the head and neck. Now, let's lock this in with a rapid recall assessment. I'm going to throw the clinical sign at you, and you give me the high-yield structure. Don't think, just react.
Ready when you are.
Efferent limb of the gag reflex.
Glossopharyngeal nerve, CN9.
Efferent limb of the gag reflex.
Vagus nerve, CN10. Remember the rule, 9 ends, 10 out.
A patient has mumps and their ear hurts. Which nerve is carrying the pain?
Auriculotemporal nerve. Again, not the facial nerve.
You need to stitch a vertical cut right in the middle of the forehead. Which nerve do you block?
Supratrochlear nerve.
And finally, a patient has a severe facial droop but can still wrinkle their forehead and raise their eyebrows. Where's the lesion?
It is central. It's likely a stroke in the cortex, sparing the forehead due to that bilateral innervation we talked about.
Perfect. If you got those right at home, you are right on track. Let's keep moving. Section 2, ophthalmology and visual pathways.
This is a heavy hitter for the MRCEM. The eyes are literally the window to the brainstem. If you can accurately analyze eye movements and pupils, you can localize neurological lesions with incredible pinpoint precision.
Let's start with double vision. Scenario 1. A patient complains of vertical diplopia.